Hello, everyone, and welcome to today's program, Key Levers to Manage the Risk in Your Risk-Based Contracts, presented by SCIOHealthAnalytics and hosted by Health Leaders Media. My name is Erica Randall, and I'm the Senior Managing Editor for Health Leaders Media. I'll be your host for today's webinar. Our program will be 60 minutes in length. The first portion of the program is a presentation followed by a question and answer session. Today's program is being recorded. Before we get started, I'd like to take a few moments to review the web conference platform. First, to ensure that you can all see the content for this event, please maximize your event window. Second, be sure to adjust your computer volume settings or your PC speakers for optimal sound quality. Third, if you look at the bottom of your console, there are multiple widgets you can use. To submit a question, you can click on the Q&A widget. It actually may be open already and will appear on the left side of your screen. You may submit your questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. And should you experience any technical difficulties during today's program and do need assistance, please click on the Help widget. That's the question mark icon, and it covers common technical issues. We're very pleased to offer you this free educational opportunity by SCIOHealthAnalytics. Now I'd like to introduce today's speakers. First, we have Rose Higgins. She is President of SCIOHealthAnalytics. Next is Linda Pantovic, Director of Compliance and Risk Adjustment at Scripps Health Plan Services. And we also have Barbara Johansson, who is Manager, Risk Adjustment at Scripps Health Plan Services. Finally, before we get started, I just want to have you make a note that an on-demand version of this program will be available approximately 1 day after the completion of the event and can be accessed using the same login link that you used for the live program. Also, a copy of today's presentation is available in the Resource List widget, which is located in the lower left area of your screen. With that, I would now like to pass the program over to our speakers.
Thank you, Erica. This is Rose speaking, and I want to just take a moment and thank both Linda and Barbara for joining me today, and hope that you'll find the content we're presenting useful to you, and also, I think, hopefully promote a dialogue with you as well. So just in terms of agenda, we're going to talk for a few minutes about what's going on in the industry and key areas where we're seeing trends emerging that are notable and some key dates that we all want to be mindful of, particularly in the area of risk adjustment. I'll spend a few minutes talking about our view from SCIOHealthAnalytics on the key levers that you can use to manage risk-based arrangements, and then Linda and Barbara will share best practices from Scripps' vantage point. As we look at some of the activity that's been going on in this area, I think the key message and takeaway is that it isn't diminishing. So even as early as yesterday, I was asked by some folks, what do we think about what's happening in terms of CMS, and are they going to be kind of backing away from some of the activities in the area of really moving value-based care and value-based payment forward? And I think the answer to that is simply no. Despite changes that may be coming forward in the different kinds of programs and approaches, I think it's quite clear that the journey toward value-based payment is well underway. And for those who have already undertaken risk arrangements, whether those are through government arrangement or whether those are through commercial contract, there's clearly a lot of activity in this area, and we expect it to continue to grow. And these statistics really speak to that. So we've seen, again, a growth in the MSFP ACO activity, so up to over 480, closing in on 500 of these entities that have taken that particular type of risk. We're seeing good outcomes being produced by those organizations, not to say that it's not greatly challenging to get to those outcomes, but nonetheless, really seeing focus and attention to achieving those. We're also seeing ongoing growth in Medicare Advantage, and so with this, we see just a year-over-year attractiveness to those seniors who want to have this additional set of benefit and really seeing value in that. And so obviously the opportunity is certainly there for us all to be able to deliver that value back to those individuals. So we don't expect to see that this is going to be reducing anytime soon. And in fact, I think the most recent statistics say that the market will probably tip over 50% of penetration by 2020 in terms of MA participation. So certainly on everyone's radar, continues to be very interesting and exciting, and also a challenging world in which to work. And as we start to move down this pathway, there are a couple of regulations that are beginning to evolve and to roll out, and I just wanted to highlight a couple of those during our opportunity today. The first of which is that the 2019 risk adjustment model that has some updates as it relates to additional conditions being included. So mental health, substance use disorder, chronic kidney disease, these are all being added to the risk adjustment model, and I think folks are really, we'll see the benefit of that, because obviously these are really predominant in the populations and certainly very important and critical areas for assessing risk. In addition to that, the number of conditions that any individual beneficiary may have, as well as some different technical updates in terms of the overall accounting in the model, is going to be taking place for the 2019 year. We see some changes as well in terms of the overall use of encounter data. This, of course, is expected, and that trend has moved now from 15% of encounter data in fee-for-service diagnosis against the 85% RAPS and fee-for-service diagnosis. We'll see that go up in the performance year of 2019, 25% encounter data and 75% RAPS. So we're beginning to see that transition. It's well underway, and I think most folks have been preparing accordingly. As it relates to STARS measures, again, some changes to the STARS measures. We're seeing a statin use in persons with diabetes, statin therapy for patients with cardiovascular disease are new measures. There's certainly always, of course, updates and removals to those, but highlighting those two areas as notable. And I think finally the 3-year phase-in. So all of these different activities now must be phased in over a 3-year period beginning with 2019. So any changes that are underway need to be fully implemented for 2022 and subsequent years. And so again, lots of activity to make sure all these things are ticked and tied within organizations, but being mindful that this is a continually iterative landscape for all of us who play in it. And just, of course, April 2nd of 2018 to highlight will be the new capitation rules and final payment policy announcements that are coming forward. So I'd like to take just a moment and set the baseline, if you will, for the levers that we want to talk about in the course of our commentary today. First of all, just getting a better sense of what's happening at the levels of risk, revenue, and network are the areas we want to focus in on. We want to find, of course, where those gaps that exist within a population, so both documentation and coding gaps that relate to revenue capture as well as quality need to be assessed. And this is obviously critical in terms of getting the proper risk adjustment assigned, and certainly also in capturing the necessary data to manage effectively that population and ensure that the quality of care is meeting the standard that the organizations want to deliver against. As well, once you've identified a bit more, with a bit more clarity, those individuals in your organizations that have those really significant needs, and how can you best attend to those, finding ways in which to either design or implement programs that you may already have in place may require some additional views analytically to be able to help you really target and pinpoint who is the most appropriate to participate, and how can you actually make sure that you're getting the most clinical and financial return for the work that you are doing. And then finally, looking at network as an overall performance measurement standard. So how can I actually assess whether my network is doing what I need it to do, and really finding out very quickly what is it within the network that isn't quite working. And certainly we want to take a look at utilization. We want to understand the cost profile across the network, and then also just the leakage from the network. So again, very important parameters for those taking risk in terms of being able to manage that overall perspective. As we continue on, we're going to focus in first on this section around identifying where the gaps exist. And as we do so, one of the things that we want to take a look at is really those year-over-year comparisons. We want to make sure that as we look at our documentation, I think it's important just to remind everybody that what CMS sees is really the documentation that counts. And so if we can't align ourselves with that information and make sure that we are being accurate in the capture of that information, then we do ourselves a disservice, as well as not necessarily then being paid properly for that. We can't necessarily deliver the care as appropriate. So we want to make sure that we get those documentation and coding gaps attended to. And that begins with just making sure that as we do a year-over-year comparison, we are matching for that data. We're identifying where those gaps are and making sure that we know which patients are associated with that, of course, and then also the providers, so that we can begin to focus our attention on closing those gaps, addressing those gaps as is appropriate. And I think it's also important to mention that while we're looking backward and doing a year-over-year comparison, we also want to be looking forward and making sure as we identify those opportunities that we're keeping those top of mind and making sure that individuals in our networks and our provider groups actually are seeing and hearing from us on where those gaps persist, and making sure that we're working with them to try to close those out. And then finally, a tool that we think is particularly useful is actually doing a benchmark comparison. So of course, looking at the individual records, determining that at the level of the provider and the individual is key. But if you can also get a quick snapshot of how you're doing against benchmark performance, that's going to help you really target those areas that you want to focus in on. And as we look at the various types of quality measures, certainly our HEDIS, P for P, and STARS are critical for all. And looking at this and just understanding that not only at the group level, but at the individual provider level, whether or not we're dealing with documentation challenges, educational challenges, compliance challenges, any and all of those things need to be looked at, and we need to be working in partnership with those individuals to try to get those to closure. We think that really trying to understand the best practices as it relates to outreach and engagement, and how do we educate those organizations on how to do that and to how good success in the doing of that, I think is also an important lever to consider. So let's talk just a moment about what we're the meat and potatoes here, actually, of what this all means. If we are finding an individual record and we just take it at first glance, what we often will see is that there's not a lot of detail in some of these documentation sets, and we want to make sure that we're finding out where those gaps are. And so here's just a simple example of what it would look like where we have a 68-year-old male who does not have the proper HCC diagnosis documentation, and certainly then that reflects in the RAS score and ultimately in the payment for that individual's care. As we consider just getting to sort of basic HCC coding, just making sure we have capture of those key conditions, then we can see an improvement in that, of course. We're going to see that RAF score go up. We're going to see the attendant improvement in the payment. But what's really critical is getting to a level of precision and accuracy here, making sure that you have a comprehensive set of documentation here that actually truly reflects the state of the individual, as well as the proper code assigned to that, so that you are really taking full advantage of the appropriate scoring, and again, noting that the risk score is adjusting here, as well as payment. So the delta between that no HCC diagnosis to an accurate and comprehensive HCC coding approach is really clearly very substantial, and in this instance, $9,500 or so is the delta. So that's going to add up to really significant dollars and cents in an organization, and we want to make sure that we're going after that as quickly and as efficiently as we can. So getting into a little bit more detail of how to do that, you want to be able to look at this across the various groups in an organization. You want to be able to identify those groups, find those PCPs or those particular physicians within that group that have associated members where we're finding challenges with some of the coding capture, and being able to look at that in terms of the prior payment year and understanding what's missing, and then calculating that in terms of the potential revenue miss that's teeing up as a result of that. So again, just making sure that we're looking at what data should we expect to see, do we see it, if we don't see it, giving some quantification to that so people can really understand the material effect here that lack of documentation really can create. And as we look at that, we want also to really begin to delve a little bit more fully into each of the providers and begin to understand where they may be located. So there may be new patterns that are appearing to us. So we're finding out this information. We're understanding that we have some gaps perhaps and maybe need to do some education and training. So we want to go ahead and take a look at that and having sometimes a geographic representation to just help us correlate. Do we have problems in the same areas? Again, this just helps us understand more fully where I need to be spending my time and attention. And really, if I've got organizations like Facility West here, which has the greatest concentration of providers and patients, we see the highest population risk, that's my highest opportunity for coding recapture and making sure my documentation situation is in order. So if I've only got a limited number of resources, as the reality in most organizations today, then this helps me get a better handle on where do I want to focus my time and attention so I can actually begin to help that practice do a better job and in turn benefit the member and the beneficiary, and in so doing also generate the revenue we need to reinvest in new programs. As we look across this set of data, then we start to also understand that maybe there's some additional program need here. So as I begin to array the kind of data that we have here, we have the ability to begin to look at this not only at the individual level and the provider level, but also at the condition level. And this is obviously important as we start to try to contemplate programs and different kinds of outreach strategies. We want to be able to understand, again, where do I actually want to be focusing my time, attention, and oftentimes very precious resource. And so one other tool that we've been able to apply to this is really a book of business benchmarks so that I can see payment year improvements or service year improvements year over year. So if in this graphic I'm looking at the darkest blue, that's 2015 service year, and if I look at the lighter blue, I see 2016 service year. So I can see some improvement in what's been happening here in terms of my coding capture and my revenue accuracy. But when I compare it to the book of business benchmark, I see a pretty big delta in a couple of areas. And so that tells me that I need to be spending a little bit more focus and attention on vascular disease, diabetes with chronic complications, major depressive bipolar situations, morbid obesity. These are keys to me to tell me that I don't necessarily have the right focus and attention potentially in those areas, and a program or additional support and outreach may be needed. So it gives me, again, more information to help construct a point of view on, and then also look to developing strategies and various tactics that can be deployed to try to change that situation and improve it for the following year. And we can also put that into the context then of just overall performance at the condition level. And this is just another way to compare data. It's just another way to begin to get a sense of where are these disparities and variations, and really begin to understand if I decide within that, how do I go get my focus, where do I want to put my resources. Again, doing some view of this from a benchmark perspective and calculating the potential value of working on these particular areas, you can quickly identify, again, just from a dollars and cents perspective, where the real need may be and whether or not I have the right tools to apply to that. But again, gives me additional information to say, for example, that my greatest opportunity based on this data and this comparison is really in addressing the major depressive, bipolar, and paranoid disorders. So looking at that as being a subset of the activities that I need to be paying attention to, and just perhaps doing some additional education and outreach with respect to. So that brings us to our first poll question. And Erica, if you wouldn't mind explaining to the audience how this works.
Sure, Rose. Thank you. So you see on your screen before you a question and some possible answers. Please select the appropriate answer for you using the radio buttons on the left side. Then you can hit the submit button at the bottom of the polling window. Note that you may need to use the scroll bar within the window to see all the options and the submit button. And you may select your answer at any time while I'm reading the question to you. Your results will appear along with those of the entire audience. So I will go ahead and read that question to you. At what level is your organization currently able to accurately identify where coding and documentation gaps exist? Your first option, response option, is not currently able to identify, provider group level only, group and provider levels, condition level only, or all the above provider, group, and condition. And I'm just going to read that one more time. At what level is your organization currently able to accurately identify where coding and documentation gaps exist? And your choices are not currently able to identify, provider group level only, group and provider levels, condition level only, and all of the above provider, group, and condition. And as those responses come in, I'm going to have Rose go ahead and just talk about the results and let us know what she thinks from this.
Great. Thank you so much, Erica.
Sure.
Well, so it's looking, I'm sorry, go ahead, Erica.
Oh, sorry, I was just going to say, here are our results, and Rose, go ahead.
Oh, thank you. So it's good to see that we have about 41% of the folks responding that you're able to see at all these different levels. That's great. Obviously indicating a level of maturity potentially of your programs and the focus areas. So that's good to see. But I will also say that it's not all that surprising to see that currently we have 26% of the group not able to identify, and a mix thereof below. And this is typically what we do experience when we're in the market, is that when we're talking to organizations, those that have been down the path a bit longer, where you see a greater level of adoption of these different kinds of programs, and certainly you're going to hear from the ladies from Scripps a little bit later on their experience, where you've got good programs in place and really been focusing, that you're really getting to the job at hand and seeing those results begin to come in. But it's really very varied, frankly, across the country and regionally, depending on where individuals are actually at in terms of their program deployment. So good information, and thanks for sharing that. We'll go ahead and get started some additional information here. And we're going to move to the next lever, which is really talking about how can you get focused on key populations and do so at a short and a long-term basis. So one of the things that you're obviously going to need to do is you've got this good information now about where those coding gaps are, where some of those quality deltas are, pardon me, and you're getting a better perspective of what's happening within the population, that you might need to go a little bit deeper, and you might need to actually ask a few more questions and understanding not only what your population risk looks like today, but kind of what the trend is. So how is it trending over time? Is it increasing? Is it staying about the same? Are there different conditions emerging that need pardon me, a little bit more attention than others? And some of the ways that we find that are helpful for organizations to actually think about this is using some additional analytics that help them focus in on those areas that may be the most impactable. And by that meaning, hey, are there some particular quality gaps here that are higher value gaps, meaning the overall clinical and financial benefit of working on those particular ones, focusing in on those, are going to be most impactful to the organization and to the individual. And so highlighting that from an analytics vantage point. Having the ability to look at the population and determine how can I actually intervene? Are these folks going to engage with me? And getting a bit of an assessment on that and understanding how folks are likely to engage based on pattern and trend that can be applied from the analytics vantage point. These are key areas that help us understand the drivers that are going to help us affect the change we're looking for and really motivate the patient and the beneficiary to actually get engaged with us in helping to manage program outcomes going forward. And this is just a quick snapshot of how that actually helps you, find those proverbial needles in the haystack. So you can start with this very large population, begin to winnow it down, find that group that's going to have the greatest likelihood for impact. Within that, find the right ways in which you can engage with those individuals to get the highest level of success. And within that, really discern the highest possible risk scores. And all of these things help you collectively focus your attention and resources in the right places to get the best possible results. Another area that we like to look at is just really looking into these buckets, if you will, the risk buckets. I think classically everybody has a high, medium, and a low risk bucket, but within that, is there another gradation of information that would be useful to us? And we think that there is, and there's a set of analytics that can help you focus in on, for example, in that first risk bucket, in that high risk bucket, we find 14.6% of our population. So we want to pay some attention there, and we want to also look at that in terms of the additional dollars and cents that are potentially available for us to actually recover as a result of addressing some of these gaps. And so this helps us just, again, really focus our attention on where we're going to find those high-risk patients and where we're going to find the opportunities in terms of clinical and financial outcomes. And then the final lever we want to talk just briefly about is how do I think about that network and how do I optimize that network? And it really is the critical asset in any kind of a risk arrangement is knowing the performance of your network and how well it can or can't address the population needs, particularly in these risk-based arrangements. And as we look at that, there are a couple of things that we want to focus everyone's attention on. And the first is really looking at utilization. Obviously, we want to pay attention to the overall trend, how and where the care is being delivered. Is it the right setting of care? Is it the right level of service? Making sure that we're looking to understand if there's variation amongst providers and the overall utilization, getting under the covers on that, understanding what that's about. And then again, applying benchmarks. Really useful to have a context in which to consider if this is on track as you would like to see it or if it's trending in the wrong direction, and having a good comparison so you can have that discussion is a very useful tool. So this brings up our next poll question. So over to you, Erica.
All right, thank you, Rose. Yes, so this will be a really interesting results slide to see after the audience has participated. What is your confidence level is the question, that you have an accurate picture of your network leakage. And just to remind the audience, you would hit one of the radio buttons that applies to you, and then you would hit the submit button. The answer choices are less than 10% confidence in knowing your or our network leakage, 11 to 25% confidence in knowing our network leakage, 25 to 50% confidence, or 51 plus confidence in knowing 51% plus confidence in knowing our network leakage. So again, just think about your confidence level and what is that accurate picture of your network leakage. And that would be less than 10%, 11 to 25%, 26 to 50%, and 51% and above confidence. So let's see what the results are. And Rose, would you like to comment on those?
Yes, thanks, Erica. Again, sort of interesting results here. So we've got a pretty even distribution, actually, in terms of that. So I would say that seeing that less than 10% confidence in knowing the network leakage, obviously as the leading score, if you will, is troubling, right? You need to have that information, particularly if you're taking risks, knowing where your network is porous and trying to find ways to repatriate that care is critical. I would say that what we find as we do analyses for organizations in this arena, we do find that oftentimes that leakage can be startlingly high, and it's not unusual to find it in the north of 40 to 50% range. So getting your hands around this is a really critical path. And so again, kudos to those that do have good confidence here that you know what that is. But again, I think it speaks to a little bit of the maturity curve just in terms of where organizations are. But this is an important lever for you guys to be focusing in on it and getting some attention to as quickly as you can. So let's talk just a little bit further about that and just to get a lens on that. So there are a couple different ways, obviously, to look at network leakage. First, looking at a facility level, understanding the providers in any one network and where that leakage is occurring. Finding out, again, as we look at the dollars and cents of that leakage, not just the overall number of units of care, if you will, that have left. It's important to find out who those outliers are and really get under the covers, and so we can see that we have a little bit of a challenge with Dr. Turner here, and we want to go in there and have that conversation, do the analysis, and understand why it's happening, because you obviously want to keep that care within your network, and particularly if you are at risk for that. You want to make sure that you're being efficient in the delivery of the care within your network, but critically understanding why there's a pattern that may be showing such a high leakage rate, and discerning that at the level of the provider, the facility, and the member is an important part of the work ahead. And as we continue on, we want to also look at what kinds of conditions may be leaking and understanding that, and then finding out further if that gives you any additional insights into what's going on. So just to sum up, as we've covered a little bit earlier today, we've talked about where those gaps are. So getting under the covers on the data, getting those year-to-year compares, finding those HCC coding gaps and the quality gaps is really critical both for revenue and quality attainment. Looking at different ways in which I can target both short and long-term population programs, using some additional analytics to help me find those needles in the haystack and really get my resources focused on the right places. And then optimizing my network performance, really getting a handle on network leakage early and often and moving from there. So with that, I want to hand it over to Linda and Barbara, and thank you.
Great. Thank you so much, Rose. Yeah, so we will go ahead and have Linda begin the next part of the presentation.
Hi, this is Linda Piantovic. I'm the Director of Compliance and Risk Adjustment for Scripps Health Plan Services. And in my office today, I also have Barbara Johansson, who is our manager for our Risk Adjustment Program. Just to tell you a little bit about us and our organization, Scripps Health Plan Service, it obtained its limited license in April of 1999. And then we eventually converted to a full license for large group commercial members only in 2015. As a compliance officer, I help file those licensures, and then also we have a unique way of bundling our risk adjustment team under the compliance team so that we have a really close eye on our overall program and be able to apply the right quality of care to all of our members across the board, regardless of the membership. But our program is based on our Medicare Advantage plan and lives, which are about 29,000 lives. Our overall lives are about 116,000. That includes our plan-to-plan agreements with other health plans and also for direct contracts with Medicare Advantage members. And so while we have a blended population, our program itself focuses on our senior Medicare Advantage members. And then overall, Scripps Health Plan Services is a nonprofit organization. We're a California corporation whose sole corporate member is Scripps Health. So we have a unique blend of family and parent arrangements here. Our overall program is really a comprehensive HCC health assessment for all of our Medicare Advantage members. We really work hard to recapture and diagnose new chronic conditions. We support the patient's health conditions and correct diagnostic coding and overall supporting documentation, including the ongoing physician education. Something that makes us a little bit more unique is we really have, or at least that's what we hear, is that we have a very robust front-end edit process to audit all of our annual assessments, wellness visits, and to ensure accurate and complete coding. We actually take the time to do that before an encounter gets out the door. We're looking at our overall annual assessments, our wellness visits, and we also have some additional advisories that we will talk about a little bit later that help us manage this population and look at the documentation to ensure that it's supported and that it's the best and highest specificity for that member based on the documentation that we're receiving. And I'm going to have Barbara talk about our Scripps corporate strategic focus, because when you're looking at our patient panel and membership, it's really important to look at it holistically and make sure that we're giving the right quality of care to our members.
Right, so this is Barbara. On this slide, ensuring successful value-based care outcomes, what the corporate office has deemed the 3 goals for this year kind of fit into this diagram here. And basically the goals are cost reduction, quality of care for patients, and patient experience. So if you look at access here on this diagram, that's one area where Scripps is really spending a lot of energy on. Even though we say we're patient-focused, which we are, our VP and president has said we need to really provide more access to our patients no matter when they need care. For example, extended hours, weekend hours, and even access to testing at various locations. So if a patient's at one clinic and they need an MRI, and at that clinic there isn't availability for 2-3 weeks, they need to look across the system. We have 5 hospitals and multiple clinic areas where an MRI could be scheduled so the patient has access sooner. So, and then they're also piloting a program of quick clinics where nurse practitioners at the sites are seeing patients who need, just quick, medical attention due to a virus or whatever versus going to urgent care or the ER. So access is the key, and quality of care with a type of visits that we've developed, comprehensive visits or whatever, trying to close gaps and meet all the necessary coding and documentation and care management for the patients when they come in. And again, it affects utilization and the endpoint, the ability to reduce cost.
So risk adjustment and quality program. At Scripps Health Plan Services, our programs historically were blended together. And in 2014, we made the decision to separate them. I spoke briefly about that. Our risk adjustment program rolls up under the compliance team, while our quality program rolls up under our medical management team. We work very closely together, and without each other, we can't be a complete team. So this graph shows you, we need to provide end-to-end partnership. We need to look at our quality and care gaps and coding gaps all at the same time, and everything blended together makes our health plan and CMS transparency. It makes us into one big family. And what what Barbara has always spoken to, and one of our, corporate energy and focus is, it's all about ensuring that we have the tools and means to provide the highest quality of care to our members that we serve. And while our team is focused on our managed care members, our organization focuses on the member population as a whole. How do we bring this together? How do we make sure that the member feels that it's being served by one team in one unit? So we want to combine those efforts so we're not contacting that member too many times, or not often enough. Either everyone's doing it or no one's doing it. So it's really important to us and our organization that we partner with our quality program and risk adjustment program to make sure that we're doing everything holistically and the best for our members' experience. So our risk adjustment quality program, I rave about our team. So I refer to them as our A team. We have 6 certified risk adjustment coders and auditors, and they have been bending and flexing, throughout the years to change with industry standards and also meet the needs of our organization during this challenging time. As you know, the overall payments are decreasing, the ever-changing evolution of healthcare. So we have taken the process and again, our coders are very unique because they're looking at things before it even gets out the door, and then we have to circle back and make sure that everything's there at the back end as well as the front end. So we have 6, certified coder auditors. We have, Barbara, who manages the team, and then I'm giving her direction. But we also have, our overall natural language processor, our front-end auditing, our chart auditing, and our physicians. We want to make sure that our physicians know what our expectations of them and that they trust our opinions, and that when we're working with them, rather it be on the front end or the back end, and we're trying to stratify and get the right type of members for them to chase, that they believe in our work and then also partner with us so that they know they can come to us as a resource, and then vice versa, us go to them with the needs of the member to make the quality of care, blended and perfect for that population. So we spoke to our comprehensive data and our risk adjustment registry in our overall population. So something that Barbara's going to speak to is we have a wonderful, electronic health record system. It's really new to us. We just converted live in April of this year. Again, our overall population is about 28,000 to 29,000 members. That's based on the Medicare Advantage, but having the ability to create our registry and our EMR to what we need it to be, looking at the populations across the board, there's all sorts of electronic enhances and bells and whistles that we are incorporating. It's taken us a little bit of time since April to really understand these things that are available to us, and then again partner with our quality team and our analytics team to help us say, okay, what are we going to do and how are we going to blend this so we're not giving that practitioner too much or not enough at the point of care. So we really look at, the membership reports, the registry, the CMS conditions, and then it also has just potential educational opportunities, and we blend both our risk and our care gaps within this tool so that our practitioner has one source of truth, for sake of a better word, and also one area for them to focus their energy on. And I'm going to have Barbara speak to this a little bit further.
Yeah, so a lot of, as Linda said, is providing the practitioners with what they need at the point of service in an easy way, because we all know these appointments are not always like 45 minutes. They could be 20 minutes, 15, or whatever, but the physician needs to accomplish as much as they can with the coding and documentation for that visit and try to capture gaps. So one of the things that has been incorporated into our EHR is we have a search button which the practitioners can use for selecting diagnostic codes. Now we're in ICD-10, which again, that was quite a maneuver to get the practitioners off of ICD-9. But all of our HCC conditions, there's about 9,000. They're flagged on the problem list in our EHR with a CMS HCC. And then, of course, you have all the other diagnostic codes. There's about 66,000 codes entirely. But the 9,000 are marked, and this is for all populations, not just our risk adjustments for our straight Medicare, for our PPO insurances, et cetera. So this is information to the practitioner on the conditions the patients have. And then with that, just at the bottom bullet there, it says identifying populations. What's really nice is we utilize the CO database, and we are able to identify, if we want to look at where are all of our CHF patients are located across Scripps, and where, which practitioners are they assigned to, and again, where are the gaps, or have they come in for visits? Has this been reassessed in this year? So we use CO for tracking purposes. We also are able to, through their prevalence reports and also through what we're seeing, we can see where we're underreporting, where we're doing well, and then that can tie into our education as far as what we want to provide to the practitioners to do a better job with the conditions that need to be, really reported well each year.
So it always starts with our team of providers. To Barbara's point, ensuring that our providers are equipped and informed and engaged. We take, so much pride in our physician education program. They know who we are. They see our faces, and we're out there often. As noted on the slide, we have a really robust physician education program. We go out to all the new practitioner educations, and we have designated time, including the nurse practitioners and physician assistants. It's really important that it's a team effort and that they know who we are. They put a name with a face, and they're able to ask questions and interact with us and, not boggled down with electronics as, modern technologies, give us that opportunity. But we want to make sure they can put a name with a face and feel comfortable with our education, with our expertise, and that they know they can reach out to us. And everything we do wants to support them and support their ability to, spend the time they need, taking care of the member and not being boggled down with, the other components of it. So we want to make it easier for them, streamlined, and so we also do a quarterly training, which includes the HCC team, the auditors, the physician leadership, and we also use internal practitioner champions. So a practitioner typically wants to hear from another practitioner. While we can educate and show screenshots and be able to be hands-on and in the system as well, it's always nicer to also have the practitioner who's doing this day in and day out and is doing a really good job at it partner with us and then come to some of our training opportunities. So to be able to show the new practitioners how it's done and how to incorporate that into their day-to-day visits so that they're not boggled down with the coding aspect. Typically our practitioners don't go into medicine, to understand the coding and those types of things. So we want to give them the liberty to take care of our members and provide the quality of care that they've been educated to do, and so partner with us to have the right tools to prompt them during their visits. We also transitioned our overall HCC education into our annual LMS system. This is sent to our practitioners on an annual basis. They are incentivized to take this training. It goes over the entire HCC program, the educational delivery system, and then it also it just goes into more of the in-depth conversations that you can't really get too granular at during the new practitioner orientation. And then we also take so when we're doing, we haven't kind of spoken to this, when we're doing the front end process, we look for opportunities there. And if there's a practitioner that seems to be an outlier or is constant asking us questions and going back and forth with us in an inbox communication, we do one-on-one educational opportunities for those practitioners. We also look at the gap opportunities that we have and reach out to those practitioners and ask them if they want to do a one-on-one training. And that way we can give them dedicated time to only speak to their practice and their nuances and being able to show them that. And then also we track and result and share with the senior leadership so that they understand where we're at as an organization. We make sure not to, have the provider's name, they're blinded, but looking at trends so we can be proactive and preventative and not reactive. So focusing on driving quality patient outcomes, our overall HCC assessment, our goal is to improve patient satisfaction. Of course, our organizational strategics, wants to make sure that we increase our RAF score. But, being part of the, compliance team and our passion is with the member and being, member-centric in everything that we do. So we do have the ability in our electronic medical record to prompt the practitioner. In the little right-hand corner there you see the alert. We have HCC gaps that are identified at the point of care. So they see that. It's a visual alert to them, and that's how they can communicate with us as well. They select that, and when they do, it drops down a list of the problems that the members the gaps the member is dealing with. And this is how they can show us that they've assessed it. We also have a different alert that's very similar to that, and when they select it, they're communicating to the coding team and telling us they performed an annual assessment. So we unfortunately don't always have, we do have the ability of having an enhanced encounter or a more longer visit for our practitioners to provide this really detailed HCC assessment. But if that opportunity is not there and the member's there for a sinus infection or cold or anything else that might be going on, they can go ahead and still show us that they've performed an assessment by clicking on this HCC gap. It says what's referred to as a BPA, a best practice advisory, and this alerts the practitioner that, number one, they've completed an assessment or are doing one, and then they also get a gap report from the problem list to show them all the other diagnoses that need assessment, and they can communicate which ones they have and have not assessed during that visit by selecting this alert. Once that's complete, we run weekly reports to identify who has and has not been assessed, and we communicate back to our practitioners on a regular basis so they know who's coming up for additional visits, what has been assessed and what's due to be assessed, and who hasn't come in at all. So again, this drives back to our front-end process. We're looking at the overall annual assessments, the wellness visits, and then anything that a practitioner, even if it's a follow-up sick visit, that they might have selected this alert for. It's really important for our practitioners to have that one spot, and this is also how we communicate our quality care gaps as well. So it's the same visual for them, and it's the same process. And so holistically, it's looking at the overall program and member-centric so they know what to expect at each visit. Erica, can you go over the polling question for us?
Sure, Linda. Thank you. Okay, so our next polling question is, what tactics is your organization currently using to communicate care and documentation gaps to your providers? The choices are emails, print, EMR alerts, notifications, combination of above, or no tactics implemented. And just as a reminder to our audience, please pick the appropriate choice for you on the left-hand side and then hit submit so that we'll be able to see your results. And again, that question is, what tactics is your organization currently using to communicate care and documentation gaps to your providers? And your choices are emails, print, EMR alerts / notifications, combination of above, or no tactics implemented. So let's see what our results are. And Linda or Barbara, would you like to speak about these results?
Yes, that's wonderful. So it's nice to see that about 60.5% of everyone's actually using a combination of all those alerts. For us, this is new, and we're just transitioning to our, enhanced EMR. So it's very good to see that everyone's actually using the combination of all the right communication tools.
Excellent. All right, so we will go on to our next slide. Linda or Barbara, would you like to comment on your slide? We may have lost sound. Can you hear me, Linda?
We're back now. Sorry about that. We had lost sound there for a second.
Okay, good to have you back.
Thank you. So engaging our members for improved outcomes. Let's take a moment to talk about this. So, we spend also, quite a bit of time on our telephonic outreach. So we get assignments from multiple of the Medicare Advantage members, and we use our customer service team to actually reach out to members who have not established care and that are new to the organization. You definitely have a blend of population, so it is a little bit more difficult to identify the members because you might have a member that's switching from one Medicare Advantage plan to another, but what we do is we outreach to the ones that have not established care, and we help facilitate that for them. So we have a monthly list. So we do this on a monthly basis, and we have our customer service team outreach to the members and help them schedule an appointment. And if they haven't selected a PCP or if it wasn't identified in our eligibility file, then we help them do that and even take a next step to transfer them back to the health plan to make sure that it comes back on our next eligibility file. This definitely is a labor-intensive process. There comes times that, our overall customer service volume just can't manage it, but for the majority of part, we minimally do the reaching out, helping them establish a PCP and get scheduled with that primary care physician. We also do a lot of mailings. We're trying to transition that to more electronic, so it is a manual process today, and we're also, looking at ways of using our registry to make it a little bit better. But we're currently sending out annual letters to, first of all, our new member guide in general. So all new members get a guide and tell them how to reach us, how to establish care, all the different bells and whistles of our organization. But then we also reach out to any patient who hasn't been seen in the last 10 months. I know that sounds like a long time, but because we have the front-end process and the outreach telephonically, we wait for a good 10 months to make sure, are they homebound, are they not? But we wanted to make sure that they haven't come in for anything else. But if there's no activity, then we also send them for an annual letter just asking them to come to us and make an appointment if we haven't been able to reach them telephonically. The last thing that we do, and when we start this effort around March, is we establish relationship, and we use an APC, a nurse practitioner or PA, and we use a centralized scheduling team to reach out to members that are identified as our highest risk population and ask them to come in for this longer visit, being able to come in and get their care fully assessed from beginning to end, and that's worked really well. We partner with the PCP, and they come into the visit as well, the last maybe 5 or 10 minutes, so the patient knows that, this is one team, one unit. You're coming in, we have this overall assessment we want to do, and we want to, provide you with the quality of care that you deserve, and it's been really receptive. We've only done this for 3 months. And we did this for October, November, and December of last year. And we had positive remarks from every member that came in and was seen. And we really, our first, I want to say about 50 to 200 patients we saw were really, really high risk, and we're so thankful for being brought in. So being transparent, across our health plan and CMS, we also have to prioritize every year ourselves. Like, where do we start? How do we prioritize and make sure that we are able to identify, the highest, risk population by still providing the quality of care and keeping up with our front-end test edit process. So we also partner with a natural language processing company that actually takes all of our senior lives and pushes it through this process that identify additional codes that we might not have been able to get to. We leverage this computer learning and linguistic pattern analysis, and it gives us the ability to rapidly validate and select, relevant ICD-10 codes. And then when we get the output file, our coders do a 100% audit check, and then we submit those through either, alternate submission file or 837 during the sweep time frame. This endeavor typically starts during early December, late November, and then right around the sweep time. So late January and early February, we're sending the output files to our Medicare Advantage health plans. Our next slide, we're going to talk about transparency across health plans and again CMS, and I have Barbara speak to this part of it.
Right, so we try to ensure that all capitated risk-adjusted members are accurately coded, including supporting documentation. and that they are accepted by the health plans and CMS. And because we're under Linda for compliance, and because we're getting all requests from all the health plans for RADV style audits where they want to see supportive documentation, our whole focus is not just coding, but was the documentation accurate? But we do go into CO to see where we have potential opportunities for doing a chart review or bring patients in. For example, this diagram here is showing the last time a chronic condition was coded in a given year. So we can use this if we see that it hadn't been coded as of this year, but it was coded last, say, the previous year. We can do it two ways. We can go in and do a chart review and see if we can find documentation that supported it, because a lot of times, sometimes the practitioners will document in the note, but they won't put it on the charging counter or report it, and it never gets to CMS. Or we can do the reverse with this thing. We can say, okay, these patients, when they come in, we don't want to produce a gap in, now we're in 2018. So we can be more proactive with, again, providing what needs to be coded basically in our EHR at the point of service.
We also have a chart audit program. Typically this happens 2 or 4 times a year. Because we also have a natural language processor and all these other initiatives, we determine how many chart audits we're going to do based on the trends that we find. And so that's how we, kind of complete, do our monthly variance reports, and we do a comparative, we use our prevalence reports to help us focus the efforts and know who we're going to chase during the time of year. And then we'll, depending on what we have going on, we'll determine which risk adjustment coders will work on which effort. And sorry, I know we're running out of time, so I want to make sure that we leave some questions and answers time because we only have 4 minutes left. But, again, thank you for this opportunity. Our overall program and overview and the key components, again, our basis is that we have an end-to-end, program that looks at every aspect of the care, not just the front end, but the back end. And then we also do a complete reconciliation of our data. We make sure that our encounters are reconciled and our HCC are reconciled. We know there's a timing issue, so that we do this, very frequently. We do monthly reconciliations and definitely during our sweep time frames. Thank you again for this opportunity.
Thank you, Linda. Are we all set then with your presentation, or did you want to talk about one more slide?
I definitely can. So again, hats off to the A team. I'm sorry, I know we were running out of time here, but our coders really did. They conducted over 20,300 concurrent reviews, 110 practitioner educations, 10 individual one-on-one opportunities, newsletters, best practice alerts, and then we are also the centralized point of contact for all the health plans, RADV, and OIG audits. And so we're just, really pleased to, partner with CO and, work on our CC risk adjustment program together. And thank you guys for the opportunity.
Great. Thank you so much, Linda, Barbara, and Rose. Now it is time for our Q&A section. We really only have time for maybe 1 or 2 questions, but we do have one that came in, and all 3 of you, if you'd like to jump in, or just one of you, but the question is the HCC gap assessment information based on diagnoses in the problem list or from claims data? Who would like
Hi,
to
Rose. I can take that, and then certainly others jump in. So essentially, it's really based on claims data. That's the source of data that we typically use to do a quick review and comparison, and then map out an opportunity analysis of where to focus attention.
Great, thank you. Anybody else?
No, that's exactly what I was going to say as well.
All right, very good. Okay, one more question, and this is for Rose. Are you seeing providers focus on risk factors across other lines of business other than Medicare Advantage?
Oh, yes, absolutely. I think certainly we see that in other areas of commercial. We're also seeing it in Medicaid. It really is just a matter of looking at the data to understand where are the opportunities to improve overall coding capture, as well as looking at the quality within those various population types. But as it relates to just population stratification and getting to clarity around where your needles in the haystack are, yes, absolutely. I think it applies across the board to all lines of service, and depending on your own population mix, you obviously may have a different slant on where you want to begin that particular journey to try to get to a higher level quality and risk analysis.
Thank you, Rose. Appreciate that. Okay, as a final polling question, CO partners with providers in evaluating potential opportunities to recapture revenue across the organization via opportunity assessments. Are you interested in learning more about these assessments? And you have the opportunity to select yes, I am interested in learning more, or no, I am not currently interested. I'd like to thank all of our speakers today. In closing, we want you to know that your feedback as the audience is very important to us. As seen on screen, at the bottom of the current slide that you'll see in just a moment, is a link to the evaluation. A live clickable link can be found in the resource list, as well as in a program evaluation widget that's at the bottom of your screen, and it will also appear in the slide window at the conclusion of the program. We would greatly appreciate your thoughts on our program today. Again, I want to thank our speakers for joining us and sharing their knowledge on this topic. Thank you so much. And to our listeners, thank you for watching and listening to our program. We hope you found it informative, and we look forward to providing you with other helpful programs in the future. Ladies and gentlemen, this concludes our program. Thank you again for joining us, and have a wonderful day.